and of course thank you for the organizing committee for inviting me to come here. It has all in all been very nice being here and meeting all of you, which was very nice, but of course it was a bit sad that some once in a while people didn't show up, but then again it's nice to be in a small group too, so it all has its advantages and disadvantages. So as we already heard, I'm going to talk about this ongoing trial. And it is a prospective, randomized, double-blind and placebo-controlled clinical trial of hydroxychloroquine in patients with erosive inflammatory osteoarthritis of the hand, so very classical parallel design, the classical RCT. And this is an investigator-initiated trial, so there's no support from pharma in this case. And it's based on a grant of the German Ministry of Science. So I just want to give you a small overview over our team. The sponsor is the clinic director of our department, Professor Burmester, and the leadership of our team and of the trial, that is Dr. Detert. And then of course we have project coordinators, study nurse. I'm responsible for the pharmacovigilance and data. We have data manager, and statistics or biometrics is being led by the German Rheumatism Research Center, the epidemiological section of them. And X-ray images are being assessed by two specialists in that. And of course we have our own pharmacy who make the study medication. There are several sub-projects on dental health and neuroendocrinoimmunology and biomarkers in osteoarthritis. And then we have a medical monitor, a clinical monitor, and of course data monitoring committee. So it's as you all know, it's a lot of people and a lot of work involved in clinical trials, and just want to give an overview. And of course we have trial sites all over Germany. This is a national German-wide study, and currently there are around 40 to 50 sites that are participating, and we're still trying to recruit some more, as we want to have 600 patients taking part. So of course we need many trial sites, but I will go into that later. So just quickly my agenda. I'm going to give you a bit of an overview on osteoarthritis in general and hand osteoarthritis, and then some facts about hydroxychloroquine, and then I will present you the trial design of our study and discuss some of the challenges that we are facing. So what's erosive osteoarthritis of the hands? You all know hand osteoarthritis. This is really a very common disease or situation. In the elderly population, almost everybody has some sort of hand osteoarthritis, or of course general osteoarthritis like knees and hips too. This is really widespread. And then, but most people don't really notice it. You can see it if you look at X-ray or at the hands. But most people wouldn't really complain about it. But then 5 to 20% of the elderly population actually really suffer from pain and hand disability or loss of function. So this is actually really meaningful. And usually one would think of hand osteoarthritis as a mild disease. And in many cases that is true, but it can actually really be associated with strong pain, restricted function, reduced grip strength, and also, and this is especially true for women, aesthetic changes. So, and often, especially erosive osteoarthritis doesn't only affect elderly people, but also younger people, younger women, and then they would of course complain that, well, my hands have gotten so ugly, I can't wear my rings anymore. And this may seem really trivial or really irrelevant, but of course for the individual this is actually really important facts or aspects too. So erosive hand osteoarthritis is a subgroup of patients with hand osteoarthritis, and characterized by certain radiographic signs that I will show you on the next slide. and this really has a much lower prevalence, but we still think that it affects around 3% of adults over 55 years, and about 10% of patients with symptomatic hand OA seem to have that. And so this is a picture. So you have the typical signs of osteoarthritis, which are little osteophytes and subchondral hyperdensities. But then you also really have those really impressive destructions, those joint destructions, like on, for example, in this joint, and this is called the sawtooth sign, and you also have the bird wing sign, which is more like this. So those are the radiographical signs, and if you look at those pictures, you can really imagine that this is really painful and, of course, really associated with loss of function. So up to date, it is still unclear if this is merely a more severe form of hand osteoarthritis, or if it's maybe even a distinct disease with specific pathogenesis. And there's still research going on that. And often, in addition to those radiographical signs and the pain, it's also associated with a pronounced inflammatory component, meaning swelling and redness and hypothermia, and also sometimes with systemic inflammation markers. That, of course, is associated with upregulation of pro-inflammatory cytokines in the synovia and the cartilage and the subchondral bone. And so that's why it's also sometimes called inflammatory osteoarthritis or erosive inflammatory osteoarthritis. So I just want to give you a small overview on the treatment options that are currently available, and this is based on the EULAR recommendations. The EULAR is the European League Against Rheumatism, who have issued a set of recommendations. So if possible, of course, we should try to use non-pharmacological therapy options such as patient education, physiotherapy, application of local warmth, for example, paraffin baths. But there are really not any clinical studies on this, so it's just, we would think that it would help, but there's not really so much evidence on it. Then the next actual recommendation, and I don't think any rheumatologist really or orthopedist would really recommend their patients that, but it is actually in the EULAR recommendations. So they would recommend topical NSAIDs such as diclofenac as a gel. And there have actually been some clinical trials on that, and it has been effectively comparable to oral NSAIDs. And another option would be topical capsaicin, so the extract of the chili, and it has also been, this has been shown to be superior to placebo in clinical trials. And also paracetamol is being recommended as a therapeutical option because it is very well tolerated, except, of course, bearing in mind liver toxicity, and it is a very cheap drug and widely available. So this has been widely used, but there are not really any placebo-controlled trials for hand osteoarthritis, but as it really helps in other osteoarthritis studies, or has been shown to be, the evidence has been shown there, we think that it also helps for that. The evidence is there for hand osteoarthritis too, but the problem was, of course, that it's not sufficient for many people, and so then also NSAIDs, like non-steroidal anti-inflammatory drugs, or coxibs, they have been shown to be superior to paracetamol. But of course, we have to bear in mind the gastrointestinal side effects and the cardiovascular side effects. And there's not so much evidence on intra-articular glucocorticoid injections, but there are hints that it may be effective. But of course, this is limited for practical reasons because you can't inject glucocorticoids into all the joints regularly. So this is mostly applied for the carpophalangeal joint number 1. And then this is more of a last therapeutical option. There is the possibility for surgical interventions. There are several operations that are being performed, and this, if performed, this is actually very effective, but often it is associated with a loss of function. So this is really used as when all other therapeutical options have failed. So the problem is that many of these, or paracetamol and analgesics and anti-inflammatory drugs, are often not effective in patients with erosive osteoarthritis. So there have been many innovative trials studying different new or other therapeutic options. And something that is actually quite well established is certain nuclear medical treatments, such as X-ray radiation or radiosynoviothesis, where you inject a radionuclear drug into the joint, which inhibits inflammation. Then there's this whole big class of Cisadoa. I'm not sure if I'm pronouncing that correct. That's the symptomatic slow-acting drugs for osteoarthritis, and those include chondroitin sulfate, glucosamine, and avocado and soybean extract, and those are, widely available in pharmacies or drugstores over the counter. And there has been some evidence that this is really helping in osteoarthritis, but we're not really sure, and the effect size is probably very small. But then again, they're usually well tolerated, so it may be helpful for some patients. And something that is in the focus of research is DMODs, disease-modifying osteoarthritis drugs, kind of in parallel to disease-modifying anti-rheumatic drugs, and those include matrix protein inhibitors and bisphosphonates and others, but this is really in an early stage, so there's not so much evidence on that either. And then there have been trials using classical biologicals like adalimumab, anti-TNF inhibitors, that are widely used in RA, and they have been tried in osteoarthritis with mixed results. So I want to give you a little background on hydroxychloroquine. I'm sure you're all familiar with it, but maybe you will hear some new things too. So the story goes that it's based on an extract from the China bark tree. And back in the 17th century, there was supposedly this Countess of Chinchon in Peru. She was the wife of the Spanish vice king, and supposedly she suffered from malaria, and then she was healed by a Jesuit father with an extract of the China bark tree. But then later on, her diaries were found, and there was actually no hint that she ever even suffered from malaria. So this might just be a nice anecdote. But we do know that the bark of the China bark tree actually contains quinine, and quinine is what's also inside tonic water by Schweppes, for example, which was first being sold as an anti-fever tonic. And so in the late 19th century, there was the first description of quinine being effective in systemic lupus erythematosus. So that's actually the first drug that was being issued for lupus. And in the 20th century, during the World Wars, the Americans and the Germans were synthesizing compounds that are related to quinine to develop drugs against malaria, because this was really a big problem. And chloroquine then seemed to be most promising, and so during World War II there were millions of soldiers who took quinine or chloroquine for malaria prophylaxis. And then it was being found that soldiers who before were complaining about arthritis or skin problems, they actually really experienced an improvement in that. So that led to further research, and hydroxychloroquine was developed, and this is different from chlorine by this hydroxyl group, and it is approximately similarly efficient or efficacious as chloroquine, but it has a reduced toxicity, and I will go into that later. Or actually right here. So what are the side effects of HCQ? Generally, it is a very well-tolerated drug. So if you look at lupus patients, for example, they take it for years and centuries, and they tolerate it very well. And it is even, if you look at the package insert, it shouldn't be taken for during pregnancy. But we know that in patients with in female patients with lupus who want to be pregnant, we recommend that they stay on hydroxychloroquine, because really it is such an effective drug in preventing flares in lupus, and there are no reports, or basically no reports on teratogenic effects during pregnancy. And so really, if a flare would occur during pregnancy, this would really be much more dangerous for the child than the woman taking hydroxychloroquine. But so side effects include diarrhea, and we've discussed that earlier on before. This might be vital for the patient. This might really be a limiting side effect. Headache, different dermatological side effects. Also, it can trigger psoriasis. So this is why it's actually contraindicated in patients with psoriasis. There have been rare descriptions of Stevens-Johnson syndrome. It can cause nausea or vomiting. There are reports that and this is not quite clear yet, that it may cause cardiomyopathy. There are hypersensitivity, there's a possibility for hypersensitivity, and hematological side effects may occur, such as thrombocytopenia, anemia. So that's why patients should regularly go have blood count checks. And then, of course, there's this big field of hydroxychloroquine retinopathy. And this is also something that's really, like, if you talk mostly about to ophthalmologists, they will be really scared of retinopathy. So and that's why in the German guidelines, or if you look at the package insert in Germany, you're supposed to go every 3 months to the ophthalmologist to make sure there's no retinopathy developing or already present. And the German Rheumatism Association has lowered it to once half a year, but of course this is still quite often going to the eye doctor. And recent data now have point towards that this is really a rare situation, or this is really a rare side effect, and it probably only occurs in patients who take very high doses of hydroxychloroquine, and probably also that it's more common in chloroquine. So actually in hydroxychloroquine, this seems to be very rare, and in patients who take it at the recommended doses probably shouldn't occur. So that's why in UK and US, for example, the recommendation is now to go to the ophthalmologist every 5 years. And maybe this will change in Germany too. So what's the evidence on hydroxychloroquine in erosive osteoarthritis? There's not much evidence, and that's really what prompted us to perform the study. There are 2 retrospective studies and 1 randomized double-blind placebo-controlled RCT and 1 open randomized trial. And the results are overall positive, but yet mixed, and all of those were really small studies. So we thought we would perform our own study, and mostly because we know that hydroxychloroquine is used in rheumatoid arthritis, and it has anti-inflammatory properties that are still not quite known how it really works. There are several pathways that it probably has an effect on, but it's actually not completely understood. But so this prompted us to do this study that we called OA Treat. So this is your classical parallel design randomized controlled trial. There are 252 patients, or 255 patients who are supposed to be randomized in each arm. Also 510 patients all in all, and 255 in each arm. And there's the left arm is taking hydroxychloroquine once a day, and this is as according to the recommendation, it's based on body weight, and the other group is taking placebo. And rescue medication is paracetamol and NSAIDs, Coxibs, and those are of course being recorded. And there's the screening visit, the baseline visit, and then 4 visits afterwards up to week 52. So this is going on for a year. Then there's a follow-up follow-up visit in the end, mostly to ask for any adverse events that have maybe occurred afterwards. And then there's an optional last radiographical visit, because there will be radiographs taken after 1 year, and then it's optional after 2 years. And that's a bit of a political background on that, because while we were developing the study, we were really trying to figure out, or we were kind of thinking there's radiographical progression in osteoarthritis is probably very slow, or we know that it's slow. So we really wanted to take X-ray pictures after 1 and 2 years. But then there were reviewers while we were applying for the grant who thought it would be unethical to take pictures once a year on a regular basis. So then we kind of agreed that this would be an optional radiographical on an optional visit to take those X-rays after 2 years. So we will see how that will go. So we have the primary endpoints. There are actually 2 co-primary endpoints, which of course may seem a bit odd, but we really thought that there should be a focus on the clinical efficacy. So that is, of course, pain and hand function, and that is being evaluated according to the so-called ORSCAN, the Australian-Canadian OA index. But then we also thought we needed to have some hard facts, and that in rheumatology is still the X-ray data. So that's we have those the co-primary radiographical endpoint. And then of course there are a number of secondary endpoints, including pain and function during the different visits, and general scores such as health assessment questionnaire, quality of life, just a whole bunch. And of course inflammatory status as by clinical examination, joint pain, swelling, etc., etc. And analgesic use is being assessed at each visit during the past 7 years, because this of course may have an impact on the outcome. And of course safety is being assessed, adverse events are being recorded. So this is a bit of a timeline of our trial. The first patient was recruited in November 2013, and as of today we have approximately 100 patients. So you can already see we're a bit back behind schedule. So we actually don't know when the last patient will be out, and I will discuss that with you later too. And we have already gotten in trouble with the German Ministry of Science, and now we're really trying to improve our strategies for recruitment, but it's actually really not that easy. But I will come back on that later. So these are the inclusion criteria. It's women and men from 40 to 80 years who can take part, and they need to have a clinical diagnosis of osteoarthritis of the hands, and they also need to have the radiological diagnosis of osteoarthritis, and this is being confirmed by our X-ray experts. And then there's also when the patients need to have the necessity of regular treatment with analgesics, because we want to make sure that there's actually really a need for treatment. And various exclusion criteria, of course, secondary osteoarthritis, which may be caused by infectious arthritis, acromegaly, and other conditions. Other inflammatory joint disease, of course, we want to make sure that there's no rheumatoid arthritis patients, and often this is actually really challenging to tell the difference, because clinically this may be really similar. And a patient with rheumatoid arthritis, if it's an elderly person, they will most probably also have radiological signs of osteoarthritis, so this is sometimes not easy. And pain syndromes. And of course, contraindications according to the package insert. And those are actually a lot too. So just Here's just a small overview over the statistics. I'm really not a statistic expert, but I hope it's a bit clear. So this is a modified intention to treat analysis, meaning that all patients who received at least one dose of hydroxychloroquine will be included in the analysis. And the first primary hypothesis, or the first co-primary endpoint, the pain and hand function, will be assessed by a multiple endpoint testing according to Loiter and O'Brien. And I have understood that this is actually a really uncommon procedure because when we published this this design in trials, there was actually some questioning on that, but our biometrician seems to be of the opinion that this is actually superior to the Bonferroni correction, but I can't really explain to you why, so I hope this is fine. But you can ask our biometrician if you have further questions on that. And so if this first primary hypothesis, if there is a significant difference, only then will we go on to analyze the radiological data. Because of course, if there is, it doesn't help anybody if there's improvement or loss, slowing down of the radiological progression if patients don't feel anything themselves. So this is really what matters most. And secondary outcomes will be assessed by parametric and COVA. And of course, the changes in the use of NSAIDs will need to be taken into consideration too. So just some few words on the pharmacovigilance. So of course, adverse events are being reported constantly at each visit, and we just issued our second annual safety report, and mostly it was gastroenterologic events and upper respiratory infections that were occurring. So of course we don't know about the association with the study drug yet, because of course all patients are still blinded and there was no need to unblind anybody yet. And there have been 6 serious adverse events, but that was mostly related to hospitalization due to conditions that were not associated with hydroxychloroquine or the patient, such as somebody breaking their foot, for example. So, just to discuss with you a bit the challenges that we're facing. This is an investigator-initiated trial, which means that there's no support from pharma whatsoever, and it's really interesting to do those studies because then you really see how much work there really is behind it and how challenging it really is. And as we were also discussing in earlier sessions, often in investigator trials, the study drug will be supplied by the pharmaceutical company, but in this case, we didn't even get that. So Sanofi Aventis, which is the German distributor for hydroxychloroquine, they said, well, no, we don't have any interest in this at all. We're doing fine. We don't want to know anything about this. And it's actually, so this is actually really expensive too, making those drugs, which I was not aware. I mean, hydroxychloroquine is really a very cheap drug if you just buy it, but then the repackaging and the, complying to all the regulatory measures that are necessary. So this is actually really a big thing. And of course, we're a small team. And many people are helping, but such as the project partners, but then of course you really have to run after them because they have their other projects too. So all in all, there are very limited resources and lots of work for everybody of us. But of course it's great fun, so I'm not complaining here, but just to tell a little bit about it. And of course we have this problem of slow recruitment, and we really need to work on that. And some reasons why that might be is that erosive osteoarthritis is simply not as common as general osteoarthritis of the hands. And then if you think back to rheumatoid arthritis trials, for example, like 10, 20 years ago when there was methotrexate and that was helping for many, but there were many whom it didn't help. But then the biologicals were being issued. So rheumatoid arthritis patients really had an incentive to take part in those trials because they were really being given something that really helped them, and they were really suffering from pain and little function of hands and all the joints. But in this case, maybe as I said, it has, the burden of disease can be high, but maybe it's just not high enough. So maybe patients actually, maybe they are doing quite fine, or they are having pain, but maybe not enough pain. And this is not supposed to be sound. This is not supposed to sound cynical, but maybe it's not enough pain that they want to take part in a trial with all that it's bringing along. And many patients are actually interested in the trial, but then when they hear, oh, it's placebo controlled, they're like, oh no, don't want to take part after all. And of course, it lasts for a year, so this means the patients have to come regularly, as in all trials, of course. And so many are complaining that it is too long. And maybe also in the trial sites, our study actually doesn't have as much priority as other bigger trials by pharmaceutical companies. And of course, we don't have our representatives visiting them regularly, reminding them. We are trying to do that by giving them phone calls and everything, but maybe really it just doesn't have as much priority for them. And also money may of course also play a little role, because we're not being able to pay as much reimbursement as pharmaceutical companies would be able to. And so there are currently 2 trials on hydroxychloroquine in hand osteoarthritis that are quite new. They were not present when we were planning our trial, but so others have actually had the same idea, and they've actually run past us. So there's the HERO trial in the United Kingdom, and they had around 250 patients with symptomatic hand OA. So this is general hand osteoarthritis, not erosive, not inflammatory. And they were receiving hydroxychloroquine or placebo for 12 months. And the primary endpoint was change in pain. And results were presented this year at the EULAR meeting. And it was actually a negative outcome, so there was no improvement in pain. And the other trial that is going on in the Netherlands is the FABIO trial. And it's actually really similar, also around 250 patients, similar to the HERO trial. And the study has been completed now, but results are yet to come. So I can't tell you what's coming out of that, but I'm expecting that it will be similar to the HERO trial. So of course, the question is, how will this have any relevance for our study? And I think we don't know, because really our study is different, because we are looking at a different subset of patients. And I think in erosive osteoarthritis with this inflammatory component, I think it could really make sense that hydroxychloroquine could help, but we really need to see that. But we will keep thinking positive, and if this trial actually could bring information that it is helpful, then this could really be a valuable contribution to patients with osteoarthritis. So I want to thank my bosses and mentors, Professor Burmester and Professor Detert, and of course the whole team and project partner of the Insider division, and of course all trial sites and participating patients. And of course I want to thank you for your attention, and I'm happy to take any questions.
I have a question. If you get a nice result from your investigation initial trial or that study, you get approval from EMA?
Well, I don't think we will take the hassle to do that. But maybe we will go back to Sanofi, and then maybe we'll be in a similar situation where you were. But of course, this is really thinking far into the future. But maybe this will just be, hydroxychloroquine is actually being quite frequently prescribed off-label, simply by rheumatologists labeling the osteoarthritis as rheumatoid arthritis, because really it is difficult to tell. So you just say, well, it's rheumatoid arthritis. We know it's osteoarthritis, but we say it's rheumatoid arthritis. So then the health insurance will pay for hydroxychloroquine. But so this will make it easier to actually write off-label prescriptions, yeah, because then there is evidence, so then you can actually prescribe it off-label. But we will need to see about that.
Is hydroxychloroquine licensed in
No, it's not.
It's not.
No. Mm-mm.
Okay.
So it's just malaria, lupus, and rheumatoid arthritis. Yeah.
And what's the efficacy of the current treatments for osteoarthritis? Are they? I mean, how beneficial is it an area where there is definitely a need? Would you say?
Yes, absolutely. Yeah. So really, what's available is painkillers, and they may not be enough. And of course, many patients, they don't want to take painkillers all the time. And then there is all of this trying to find out something that's really stopping the progression.
Yeah.
But there's really nothing yet there. There is intensive research actually going on, and I mean this is not only talking about hands, but like knees and hips too, because this is a huge problem. Good, thank you very much.
One question.
Yeah.
The recruitment rate is very low.
Sorry? Yes.
Your recruitment rate is very low. You have 48 centers. So are you going to increase them, you said?
We're trying to increase them, but of course the most important thing is to actually motivate those that are taking part. They have signed everything. There's so much paperwork for them too, just being part of the trial, even without recruiting. So this is really our biggest focus now, to actually motivate them to find patients. But so if you look at the numbers, you can think that there are actually many sites who are not recruiting at all, and I've been trying to point out some of the reasons for that, but we don't really know. Yeah.
And the second thing is that what steps are you taking to cover up for the cardiovascular adverse events of this drug? Because it is known to have cardiovascular adverse events, including QT prolongation and others. So what steps are you taking to monitor the cardiac adverse effects of the patients?
Well, we're really not. There's no electrocardiography that we're taking, for example. This could be something because when we were designing the study, we were of the opinion that it was not that major of a problem, and I think it really isn't. I think data from lupus, for example, has shown that there's lots of data available, actually, mostly from lupus, because this is really the main indication still. So we're of course being aware of everything, and all adverse events are being taken seriously. But there has actually not been a problem with that. Yeah.
And what dose are you using?
For patients under 60 kilograms, it's 200 milligrams per day. Then for between 60 and 70, it's one day you take one capsule of 200, the other day you take 2 capsules of 200, and then over 70 it's 400 milligrams, so 2 capsules. Yeah.
Those comparable to that used in lupus.
Yeah, that's just according to the package insert. Yeah.
Okay, so it really is, just switching indication.
Yeah.
Okay.
Thanks. We wish you all the best. Thanks for your presentation.
Thank you so much.
It's difficult. I understand it's difficult when you have an indication like osteoarthritis, erosive. You know, the number of patients to get in is difficult, and also when you talk about interest from the pharma industry, it's not where a lot of the big pharma are developing their research at the moment. It's still very much, they're targeting the large molecules.
Yeah.
So to get any, my France nephew is not, what osteoarthritis are interested in that, which seems to be what's happening. It's a shame though, because
it is a shame, because I mean, if somebody would actually find a good drug for osteoarthritis, I mean, this could be a big seller.
at the end of the day, I'm hoping one day, I don't know if it takes me, but it's a very good possibility that I will. And I think a lot of patients, it's almost, it's a lot it's undiagnosed.
Yeah.
Because people just think that you get older and
Exactly, and then
that's what happens.
Yeah.
What is happening now is that's why people are opting for alternative medicine. In such cases, it's especially in such indications.
Exactly,
They get
like
relief, they
avocado
want
or
relief,
soybean
they don't
extract,
get it
yeah.
from the drugs. Then they go down to other things like pressure or whatever. There's so many